Hello, everyone. Thanks for joining us here at Temple Health for today's live webinar and Q&A, Post-COVID Recovery and Monoclonal Antibody Infusion Clinics available at Temple University Hospital. We're joined today by our panelists, Dr. Claire Robb, who's Senior Vice President and our Chief Clinical Officer at Temple University Hospital. Dr. Gerard Kreiner is the Chair and Professor in the Department of Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at Temple University and is our Director of the Temple Lung Center. And Dr. Daniel Salerno, Associate Professor in the Department of Thoracic Medicine and Surgery here at the Temple Lung Center. There will be a brief presentation followed by question and answer. And we ask if you do have any questions, please type them into the Q&A at the bottom right of your screen. And we'll be sure that Dr. Kreiner and Dr. Robb and Dr. Salerno are available to answer them. We'll also be recording this session today. And so anyone here with us would receive a follow-up email where you can review at a later time. Dr. Robb, if you could kick us off by describing the patient types for these clinics.
The first subset is for patients who are determined to be long haulers. We define that as anybody who has symptoms outside of a 3-week window of testing positive that you feel as primary care providers and health plans that they need to be continually seen by a pulmonologist. And we will be able to accommodate those patients in our regular pulm clinic because they're no longer contagious. However, there are certainly patients who don't require hospitalization, maybe don't require oxygen, but still need to be seen within that contagious window of what we're saying is 3 weeks. And so those patients that you may identify not needing the hospital, needing a little more intensive overview by our experienced pulmonologist can come to our COVID hospital in Boyer, which I think many of you have heard about, and be seen in person by our pulmonologist. There's also an option, if appropriate, based on their symptoms, that they be seen by a televisit. So, besides offering that, the big thing that we really want to offer to you and your patients is the infusion clinic as well. There aren't many centers in the area that are providing this. So what is the infusion clinic? So again, it's an infusion clinic held in our Boyer building. We provide there both the Regeneron cocktail as well as the Beblamizumab cocktail. Well, it's not a cocktail, sorry, it's just one monoclonal antibody. And so based on the criteria, which Dr. Kreiner will review, we can accommodate those patients. How do you get your patient into the clinic is the next question. So in order for your patient to be considered for the EUA use of the monoclonal antibodies, they have to have a documented COVID positive result in our system, or on paper, or something that we can scan in to sort of attach to the infusion. It can't be hearsay, if you will. When you have this patient, we ask that you or your patient call 1-800-TEMPLE-MED. That's our main number. And we will immediately connect your patient with our pulmonologist who will screen the patients for appropriateness. If they're appropriate, we intend on trying to get patients in the very next day. We have space to accommodate these patients. Dr. Kreiner or Dr. Salerno will go through how beneficial these really are. But like I said, we're one of the few places in the city that is able to do this and to turn it around real time. And the results have, it's proven in the New England Journal that this keeps patients out of the hospital. So I think we'll go through any logistical questions and questions after. I'm going to turn it over to Dr. Salerno to run through the clinical. But again, you or your patient, whatever is easiest, to call 1-800-TEMPLE-MED and to get the patient scheduled for either clinic. Dan?
So, can you guys hear me?
We do.
Hi, everyone. I'm covering for Dr. Kreiner today. Can you guys see my slides right now?
Yes.
Okay, let me make sure I have them here. All right. So these are slides from Dr. Kreiner. I'm just going to go over them quickly, and then we can do questions and answers. Um, First, just a little bit about the pathogenesis of COVID-19. Is this fascinating virus that has kind of put our lives upside down. But anyhow, it's an RNA virus. It has the spike protein. It gets into the cell and then uses the machinery to make copies of itself and reproduce. And then the very important part of this is that it has this spike protein that covers and then interacts with ACE2 receptor in the human cells, and that's the way it gets into the person. But there's these antibodies that can neutralize this interaction, and that's kind of what we're talking today about. The New England articles, the first one is the one that covered the cocktail. This is the one made by Regeneron. This one was a double-blind phase 1-3 trial that covered non-hospitalized patients with COVID-19. These antibodies are fully human, and they act against the spike protein. And there were 3 arms for this study. Different doses of the cocktail, 2.4 grams, 8 grams, and placebo, and they were prospectively studied to see what was the immune response in people who were antibody naive or people who were antibody positive from before. So as you can see here in the figures, the viral load, these ones are the naive people, serum antibody negative. These ones are the positive people. And then you see each as days go by and the viral loads. So placebo is higher. There was not too much difference between the 2 doses, but it keeps going that way. And it's much more noted in people who were antibody negative. This one, it has to do with how many copies the person has, the viral load initially. We believe that the higher the viral load in general, you can get sicker. So it seems to make a bigger difference, as you see here towards the right, in people with higher initial viral load. And then this is in the overall population, again, with the 2 different doses. This table represent the adverse effects. And then we have the low dose, the high dose, combined data, and placebo. And there was not too many side effects. They're listed here. Some very rare occasions, there were hypersensitivity reactions. Some of them have been covered in the media. And in conclusion, it reduced the viral load, especially in patients that were antibody naive to begin with. The other antibody came from the BLAZE-1 investigator. This was a phase 2 trial that had outpatient with mild to moderate COVID-19, and they got a single infusion of the antibody. Here, instead of 2 doses, they had 3 different doses or placebo. And the primary outcome was the change from baseline in the viral load at day 11. Baseline characteristic from the 2 groups, the combined with the antibody and the placebo, pretty similar groups. Some of them we can probably extrapolate to the population that we see here in North Philadelphia. And then some of the figures from the article. This one is an interesting one. If you see the viral load, and somehow they compare non-hospitalized with hospitalized. You see how it keeps going down, but doesn't go down that much when you're hospitalized. That has to do with this thing that we've been seeing, that maybe there is some problem with viral load from the beginning, and people that cannot clear too much viral load continue to be sick or get sicker. And this is just showing you, again, viral load and cumulative probability with the different dose and the placebo here. For adverse effect on this study, similar to the other one, not too many serious. side effects. The table is here. And then there were also following relate hospitalization visit to an ER, 1.6% in the antibody group, 6.3% in the placebo group. So what we offer at Temple, first is this is just treatment for outpatient. Once you get to be an inpatient, you don't qualify anymore because or the severity of your condition. So emergency use authorization, we have the cocktail by Regeneron, casirivimab, and indevimab, and the non-cocktail one, the bamlanivimab. And then we can offer also clinical trials. We have, with all these monoclonal clinical trials that people can get into, we also had inhaled and short-term IV remdesivir, and then you can go into compassionate use as well. So the UA for the monoclonal, this is approved for adult and pediatric patient who had a positive SARS and 12 years or older. And this is kind of the important part here. You have to be high risk. You have to meet at least one of these criteria. BMI more than 35, chronic kidney disease, diabetes, immunosuppressed, receiving immunosuppression treatment, more than 65 years of age or more than 55, and having cardiovascular disease or hypertension or COPD or other chronic respiratory disease. And also very important, you have to be less than 10 days from symptom onset. The sooner you get this, probably the better outcome you may have, as many things that we do in medicine and specifically for COVID treatment. Just quickly talking about the long haulers in COVID. Since the beginning of the pandemic from China, we got some papers telling that many people have persistent symptoms and also persistent radiologic abnormalities. This was a series from Italy that also came at the beginning of the pandemic, I believe. And you can see this figure is pretty nice, how it shows how things happen during acute COVID and then in the post-COVID. And you can see as fatigue is present almost in everyone and in a big amount of people also after. And dyspnea are kind of the same. So those two are pretty high in the top. And then the other ones change a little bit more. And here are just some interesting CAT scans from some of our patients. Many times, kind of sadly, we've seen admissions in which wife and husband come together. And sometimes they have very similar age and maybe even comorbidities, but they do very differently because of the many things that we still don't understand about these conditions. So the wife in admission, you see she had a lot of opacities in both lungs, some of them ground glassy, some of them almost consolidation, and then it kind of clears after several weeks after symptoms. Husband didn't have too much on admission, but then after in follow-up seems to be developing interstitial change, almost early fibrosis here in the left base. This is just some measurement of their inflammatory markers. And another one here that admission has a little bit of ground glass, patchy here and there. Then 4 days after admission seems to peak and much more widespread ground glass opacities in both lungs. And then 6 months post-admission, so a long time after, you've seen some residual ground glassy, maybe even mosaic pattern here and there, and maybe early fibrosis too. These are just, we came with the idea of having the post-COVID clinic early in the pandemic. Probably, I think in April, we saw some of our first patient. And this was something that we created here at Temple, the flow diagram of how we were going to manage them. So this initial one was the one that we planned for 1 month after discharge. And this one is the one that it was planned for 3 months after discharge on these patients. Basically, we were following on them images. We were doing inspiratory, expiratory CAT scans just to see if there was an element of post-viral bronchiolitis with air trapping. And we were also doing pulmonary function tests, and we were also doing the inflammatory markers and COVID antibodies to follow on them. This one, I think, is part of a grant that we're applying, Dr. Kreiner applying, about how we follow these patients, both hospitalized and non-hospitalized over time, and what type of visits and blood work and image studies they're going to get. And we have then the infusions, as we mentioned. These have to be outpatient with recent COVID-19 infection. And then we have outpatient who had prior COVID-19 infection that can be seen in the COVID clinic, or if they're more than 3 weeks post-infection and they have persistent respiratory symptoms, we see them in pulmonary outpatient clinic. This is some of the ways that through Epic, providers can put orders for patients to be seen in our clinic or be referred to our infusions. And also for patients that are not affiliated with us, people can call 800 Temple Med to schedule appointments. I think that's all.
You got it. TK, do you want to start with the questions?
Definitely. Yeah, thank you both for providing the context around those two clinics. The first question that we received here is around the long hauler patient type, and it asks, what do you see as the role for antifibrotics in the long hauler patient population?
Claire, you want me to take that?
Sure.
I think it's too early to say. Basically, hopefully we will get some prospective data about that. That's a great question. But first, you will have to put fibrosis on the patient, on the CAT scan or something. And then probably to get approved with antifibrotic, you will have to prove that is progressing over time. So you will probably need to have more than one CAT scan and more of one pulmonary function test.
Thank you. The next question that we have says, does the severity of the initial COVID infection determine to a large extent the severity, the type of persistent symptoms, and the duration of the post-COVID illness?
I'll take that one. So I think the answer is not necessarily. So certainly, patients that are in the ICU and hospitalized tend to have worse lung findings, 1 month, 3 months out, and so on, which is not unexpected. But as Dr. Salerno showed, there are also certainly patients who don't even require hospitalizations, but then go on to develop long hauler type symptoms. So it's not a directly proportional all the time.
Another question that we received is, in the previously healthy adults who get the long COVID, chronic fatigue-like symptoms, the persistent dyspnea, the vague chest discomfort, at what point, asking 6 weeks post-discharge, 12 weeks post-discharge, when would you test with imaging, PFTs, EMG, echocardiogram, et cetera?
Dan, you want to answer?
Sure, thanks, Claire. So in our clinic, pulmonary clinic post-COVID, we were doing the images pretty soon after, 4 to 6 weeks after. And our experience is there were some people that have almost complete resolution. There were some people that still have some ground glassy things. And there were some people that were starting to show maybe early fibrosis and those kind of things. Regarding studies for muscle or echocardiograms, I will defer more that to specialized cardiology post-COVID clinic. We're also seeing some of the symptoms seems to be rheumatologic, like joint pain and those kind of things. So I think some of the rheumatology sections in different hospitals will do also post-COVID care a lot here.
Another question that just came in asks, we've heard of MAVS not being used much. How do you facilitate the provision of MAVS to those patients who can benefit from them?
So I'll answer that. I mean, there is, contrary, I think, to what people think, there is enough supply at this time of the MAVS. There's just not actually enough clinics being stood up in time, and not enough awareness to really use it. I think across the country, we're using 20% of all the supply we have. So that's really our, what's provoking us to do this, is that we do have supply. We do have the ability to order more based on the amount of patients that we have. And clearly we have the space and plan to give it. So that's why we're working on getting the word out.
Thank you, Dr. Rob. The next question here asks, a 9-month long hauler. Okay, so we have a 9-month long hauler and none of the lung scans, the CT angio or the X-ray, have shown any issues. Are there any scans or tests that have shown issues in these scenarios?
You want me to take this?
Yeah.
So again, maybe you can get a little bit further away if you do an inspiratory expiratory, because maybe the expiratory is going to show you air trapping. Maybe you're going to find something else that maybe was there before COVID, such as excessive dynamic airway collapse, etc. Then we're doing some research with a company that can do like computer analysis and CAT scan. And they're analyzing for us blood vessels. And what we're finding is that some of the people with COVID, they seem to lose some of the very tiny blood vessels, the ones that are less than 5 millimeters in area. And that's not going to be seen in a regular CAT scan unless you do sophisticated analysis. So maybe that's part of the problem. And we actually found some correlation of that with low diffusion capacity. So some of our post-COVID people seem to have only just low diffusion capacity in follow-up and kind of normal image. So maybe they're part of that.
Thank you, Dr. Salerno. The next question that was asked here is, if I was referring a patient for the infusion, is this covered by their insurance? And if not, what would the cost? What is the cost? And can this be billed through their insurance for the infusion? Maybe Dr. Rob, could you field that, please?
So the drug itself, since it's EUA, it's provided by the government, not much different than remdesivir on the first phase of COVID. So there is no charge to the patient, and there's actually no charge to us. It feels weird to say that because it's never that way, but that's good. There is a fee for the, providing the actual infusion. And if a patient is insured, we will charge their insurance, but certainly there are patients who are out of network, and there are also uninsured patients, and we will see those patients without a charge. So we will not charge people who are uninsured or underinsured or not in our network. We are prepared to accommodate everybody that you send to us.
Thank you. I apologize if there's any feedback on my audio. The next question that we have here is an operations question, and it asks, how many patients are infused daily? How many days a week is this offered? And what does that process look like?
So right now, we have one nurse who can do up to between 4 and 5 patients a day. We offer it Monday to Friday. By the time you get in and you do all the paperwork and get the infusion, and you wait after the infusion to make sure you don't have any reactions, about a 3 to 4 hour process for the patient. We're doing it starting at 1 o'clock each day because, again, right now we don't have more than 4 or 5 a day. That being said, if we have the patients, we will continue to staff up to accommodate all of them. So it really should not be a problem from the referring sense.
Great, thank you. One other question here is, how does the monoclonal antibody interact with an anti-COVID vaccination?
I'm not sure if I want to take that one.
I don't know.
Yeah, I think it's kind of a little bit of uncharted territory right now.
Understood. And also, can you describe how many locations or where the infusion center is located?
Yeah, so the infusion center right now is located at our main campus. It was just the easiest place to start because like we had the COVID building and, you know, designated COVID spots. That being said, like I mentioned before, we are prepared to accommodate as many patients as we can, you know, treat. And if that means opening other locations at Jeans or Episcopal or Northeastern campus, you know, we are prepared to do that. But for right now, we don't want to open until other locations until Maine is full.
Great, thank you. And Dr. Salerno, can you confirm that the long hauler patient type can be seen in any of the lung center outpatient clinics?
Absolutely, sure.
Great. Well, at this point, I would say that we've answered the majority of the questions. I believe all the questions that have come in. We can accept others if you would like to send them in here in the next few minutes. But as we wait potentially for those, I would just like to thank both Dr. Robb and Dr. Salerno for taking the time to share this information. I think both are very valuable for those two patient types that you described, and also would also like to personally thank both of you for your leadership here at Temple Health through this whole 10 months plus here that we're heading towards, and everything that you've done has been exceptional and much appreciated.
DK, can I just add one thing? If there's any information that was missed or you come across a patient with further questions, you can reach out to any of our Temple team or me specifically. And we have also have business cards / postcards that are in English and Spanish that can be provided to patients. So if you feel like, you know, having a card to give the patients since they kind of have to schedule themselves is helpful, let us know. We'd be happy to ship those to you.
Thank you. And we did get one more question here that came in that I'll ask, that asks, what type of therapies are being used for the post-COVID patients with shortness of breath or some capacity of reactive airway disease?
Dan?
Sure, I can take that. So different things. If they have persistent ground glass infiltrates and they're still short of breath, you can argue that they can get steroids, and sometimes they get symptomatic improvement, image improvement, and radio and pulmonary function test improvement. I recently had a patient on that scenario, and her diffusion capacity was like 60-something%. I give her just some oral corticosteroids for 1 or 2 weeks. Diffusion capacity went up to 70-something, and she felt much better. So that's one. If you are getting into a reactive airway disease type of scenario in someone who didn't have that before COVID, of course, you can try inhalers that we normally use for that. You can even get into looking if they have like an eosinophilic phenotype in case you get to need more advanced treatment, etc. And then if you're going into more like an ILD type of situation, then you have to wonder if this is more like an inflammatory ILD or you're already on a fibrotic phase, and then you can argue about antifibrotic as we were talking before at some point. But some of these things we're still kind of learning what to do, and hopefully we will get prospective data from different studies to guide us in those decisions.
Excellent. Thank you, Dr. Salerno. And that, folks, I will say is the conclusion of our webinar today. I just want to reinforce, for the patients appropriate for the infusion center and this current program, please refer those patients to 1-800-TEMPLE-MED, and the process which Dr. Rob described will lead them to the care they need. For those in the long hauler patient category, you can refer that way or through your primary Temple contact to get those long hauler patients to the Temple Lung Center clinics. And if there's any other questions as you see them arise, feel free to reach out to us and we'll do our best to help. And as Dr. Rob said, this call will be distributed to those who attended, so hopefully you can review it in detail when you have the chance. Thank you again for joining the meeting today, and we look forward to continuing to work with you here at Temple Health.